Good morning, everyone. Welcome to the opening and kickoff ceremonies for the 18th National Health Research Forum for Action. The Department of Health, DOH, Department of Science and Technology, Philippine Council for Health Research and Development, or DOST PCHRD, and the Ateneo de Manila University Institute of Philippine Culture, or ADMO IPC, are providing this webinar as a public service. But it is neither a legal interpretation nor a statement of DOH, DOST PCHRD, or ADMO IPC policy. Reference to any specific product or entity does not constitute an endorsement or recommendation by the DOH, DOST PCHRD, or ADMO IPC. The views expressed by speakers, facilitators, and viewers are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Views and opinions expressed by DOH, DOST PCHRD, or ADMO IPC employees are those of the employees and do not necessarily reflect the view of the DOH, DOST PCHRD, and ADMO IPC, or any of its officials. We now introduce you to the session facilitator for today, Ms. Frances Onagan.
Morning, everyone. The Philippine Standard Time is now 9:01 a.m. Good morning. We welcome you to the 18th National Health Research Forum for Action. The purpose of this very first online forum is to showcase local evidence, breakthrough findings, and developments in health policy and systems research geared towards universal healthcare realization in the context of the current COVID-19 pandemic in the Philippines. Today's session is entitled Transparent Governance and Accountability in the Face of COVID-19. I am Frances Claire Anagan, and I will be today's discussion facilitator. To formally start our program, we begin with a short prayer and the singing of the Philippine National Anthem.
Let us put ourselves in the holy presence of God. Father in heaven, always merciful and giver of life, we humbly ask that you bless each one of us, from the speakers, program committees, guests, and participants. Guide us to make better decisions as we incorporate what we will learn throughout this activity. Thank you for the infinite blessings and countless opportunities. Lord, today, as we start our activity, may we always be grateful to learn new things. Shed the light of your wisdom and bless each one, especially our speakers, as they will share their knowledge to us. Through your mercy and grace, may peace and utmost understanding shine and dwell unto us. Almighty God, accompany each one and help us concentrate for us to gain more knowledge as we listen attentively. This we ask in your name. Amen.
Ladies and gentlemen, the Philippine National Anthem. So good morning, everyone. Once again, thank you for joining us for the official kickoff ceremony of the 18th National Health Research Forum for Action. We would like to acknowledge and thank everyone, all our viewers joining us all over the country. So welcome once again. To start the program, we would like to hear a few remarks from our distinguished guests present. So let us hear some welcome remarks from the Honorable Undersecretary Dr. Mario Villaverde from the Department of Health.
It is with great pleasure that I welcome you all to the 18th National Health Research Forum for Action. This forum has come a long way, and we have learned so much through the years of conducting it. I remember that I was the director of the Health Policy Development and Planning Bureau when we spearheaded this activity. As envisioned, this event had been an annual melting pot of technical experts from various fields, academicians, development partners, and different stakeholders who are willing to share ideas and studies for the betterment of the Philippine health system. Last year, this research forum was brought to a new level. Instead of usual national forum like this, regional health research fora were conducted in Tuguegarao City and Iloilo City. Such move underscored the importance of localizing efforts at achieving universal healthcare. Moreover, regionalizing the conduct of the event further promoted the culture of research and evidence among local researchers, decision makers, and implementers. The passage of Republic Act 11223, or the Universal Healthcare Act, is crucial to the conduct of health research in the country. It has a provision that specifies evidence-informed sectoral policy and planning for universal healthcare. The law even highlights the conduct of activities like this, and I quote, participatory action researches on cost-effective and high-impact interventions for health promotion and social mobilization shall form part of the National Health Research Agenda of the Philippine National Health Research System, which shall also be mandated to provide adequate funding for the conduct of these researches. During this COVID-19 pandemic, the DOH, in collaboration with the DOST PCHRD, has remained steadfast in providing opportunities for evidence generation and dissemination. It is actually in situations like this where good quality research and evidence are very much needed. Policy and decision-making, especially in times of crisis, should be built from sound basis. This year's National Health Research Forum for Action, with our team Realizing Universal Care Amidst Pandemic, will again be conducted with another first. Instead of the usual venues like hotels and convention halls, the forum is now virtual. Hence, despite the pandemic, the legacy of the Research Forum continues. It remains as an avenue for policy, research dissemination, and point of convergence among researchers, policymakers, academicians, and technical experts in various fields that impact on health. Finally, let me say that there is so much to learn from the COVID-19 experience. It is essential to highlight the lessons from our country experience in terms of response, management, and surveillance. In this forum, let us open an intellectual but action-based discourse on ways forward. It is our fervent hope that you will find the 5 sessions of this research forum spanning from September to November 2020, as engaging and informative as the previous fora. Most of all, we hope that it will also inspire you to act in whatever capacity you are in to realize universal healthcare for all Filipinos. Once again, welcome and mabuhay.
Thank you so much, Yusek Villaverde. And now let us call on the Honorable Executive Director, Dr. Jaime C. Montoya, the Executive Director of the Philippine Council for Health Research and Development, Department of Science and Technology, for his opening message.
Distinguished guests, friends, ladies and gentlemen, good morning. The Department of Health, our partner in the Philippine National Health Research System, NHRFA, leads the holding of this event, the 18th National Health Research Forum for Action, or NHRFA. As COVID-19 continues to challenge our healthcare systems and endanger the health of our communities, this year's NHRFA with the theme Realizing UHC Amidst the Pandemic intensifies the call for universal healthcare in the country. As the National Coordinating Agency for Health Research and Development Efforts, the Department of Science and Technology Distinguished guests, friends, ladies and gentlemen, good morning. The Department of Health, our partner in the Philippine National Health Research System, or PNHRS, leads the holding of this event, the 18th National Health Research Forum for Action, or NHRFA. As COVID-19 continues to challenge our healthcare systems and endanger the health of our communities, this year's NHRFA with the theme Realizing UHC Amidst the Pandemic intensifies the call for universal healthcare in the country. As the National Coordinating Agency for Health Research and Development Efforts, the Department of Science and Technology, Philippine Council for Health Research and Development cannot emphasize enough the key role of health research and development in building a robust healthcare system. By providing research results and scientific evidence to policymakers, health R&D guides the creation of an inclusive, accessible, and sustainable healthcare policy and strategic framework towards an efficient healthcare system that responds to the needs of the people. With DOH defining the health challenges of the country, the research community responds by strengthening our efforts by providing information towards evidence-informed, universal healthcare policies and innovations that will ensure the health of every Filipino, even beyond the COVID-19 pandemic. On behalf of the DOST PCHRD, we express our continued support and gratitude to our health researchers who remain steadfast in generating research-based solutions, contributing to our goal to make Filipino lives better. To the DOH, we look forward to strengthen partnerships and future collaborations that will forward health research as a tool to better address the healthcare needs of our communities. I hope that this event will not only provide us a vision of our journey towards universal health care in the midst of this global health crisis, but more importantly, remind us that realizing universal health care is possible with solidarity. Lagit-lagi para sa kalusugan ng bawat Pilipino. Maraming salamat po.
Thank you, Director Montoya. And now let us hear the keynote address from the Honorable Secretary of Health, Dr. Francisco T. Duque III.
To my esteemed colleagues in the health sector, research and academic institutions, government and private agencies, civil society organizations, and development partners, ladies and gentlemen, good morning. Amidst this unprecedented COVID-19 pandemic, we cannot and should not stray from our vision of attaining universal healthcare for the Philippines. We recognize the distinct challenges that we are now facing as a nation in pursuit of this vision, but we remain as steadfast as ever in our goal. The COVID-19 pandemic has strained our fragmented health system and surfaced the gaps which have bored through for many years. It is alarming how vulnerable populations have been disproportionately affected by these risks, often entailing grave consequences. These sobering realities highlight the importance of the fundamentals, a health system with strong primary health care foundations, with robust public health functions such as surveillance and health promotion. If there is one major lesson that can be drawn from this public health crisis, it is of the urgency with which we must forge ahead to achieve universal health care and create networks, integrated and collaborative systems across and within levels of healthcare. The Universal Healthcare Act set the stage for the transformation of our healthcare system toward ensuring greater access to essential and affordable health services and addressing health inequities through reforms for local health system integration, healthcare provider networking, healthcare financing, and governance. How this list of reforms can be done in such challenging times is daunting, to say the least. It will certainly be difficult, but not impossible. This is where the generation and use of evidence must play a role to better guide our decision making and actions and transform a litany of challenges into a golden opportunity. The National Health Research Forum for Action is a time for health research stakeholders from around the country to congregate, showcase the latest local research, and recognize the country's best and brightest. Though we are not together physically this year, we hope shifting to a digital platform provides access to even more participants than past fora. Let us take this opportunity to indeed harness the potential of the Philippine research community to inform and influence policy and decision making through high quality evidence and discussions. May this be a venue to spark further learning, innovation, and collaboration toward universal healthcare. Lastly, I wish to extend the DOH's appreciation to the technical experts, researchers, and scientists for their invaluable contributions to the COVID-19 response. The Philippine health research community can be assured that they have been represented well by these individuals and that through their contributions, we have been able to navigate through this difficult time. We hope to continue this collaborative relationship with the research community to rise above this crisis and realize universal healthcare. Maraming salamat po at mabuhay tayong lahat.
Thank you so much. Thank you so much, Secretary Duque, for sharing with us your insights on how health research can help us push for universal health care amidst the COVID-19 pandemic. Let us now open our research presentations for today's session with the theme Transparent Governance and Accountability in the Face of COVID-19. This session is meant to contribute towards understanding the role of evidence in policymaking and transparent and accountable governance during public health emergencies like the COVID-19 pandemic. This session will be highlighting the work of researchers and their role in the COVID-19 response. The lineup of the speakers this morning will be Assistant Secretary Kenneth G. Ranquillo, who will be presenting the health sector performance, Dr. Antonio Dance from the UP College of Medicine, who will be presenting the effectiveness of preventive interventions for COVID-19 response, Ms. Megan Battle from ID Insight will be presenting the results of a COVID-19 KAP study conducted in an LGU, and Dr. Medea Cabamalan will be closing off this session with her presentation on what the changing age demographics have to do with COVID-19 deaths. So before we begin, here are some house rules for the webinar. If you encounter connection problems during the webinar, please click the reconnect button found at the top of your screen. Please use the chat box on the right side of your screen for questions and comments related to the webinar at any time. They will be read after the presentation. Please state your name and affiliation with your questions and comments. And finally, we value respect and courtesy the most during our webinar sessions. So to continue, let us now call in ASEC Kenneth G. Ranquillo from the DOH for updates on the performance of the health sector.
Good morning. Does everybody hear me?
Yes, sir. We hear you loud and clear po. Thank you.
A pleasant day to each and everyone. Allow me to share you the Philippine health sector performance, highlighting the progress, the challenges, lessons learned, and proposed mechanisms for improvement. We will breeze through the progress in the implementation of the commitments in the policy statement and strategy map, overall sector performance against the targets and trends in performance for selected indicators over the previous fiscal years. The Formula 1 Plus for Health, or F1 Plus, is the sectoral strategy that has been adopted by the Department of Health in 2017 as a blueprint of the universal health care. As shown in this strategy map, the DOH envisions Filipinos to be amongst the healthiest people in Southeast Asia by 2022 and in Asia by 2040. The Department of Health, through F1 Plus, strives to lead the country in the development of a productive, resilient, equitable, and people-centered health system. The strategy places heavy emphasis on primary care as a key element of responsive healthcare provider networks. 3 years after the implementation of F1 Plus strategy, we have managed to gain success in core indicators such as maternal and infant mortality ratios and stunting among under 5 children, among others. Shown are the quick wins on the health outcome indicators reflecting the baselines, current data, and the 2022 targets. In terms of measuring the responsiveness of the health system, a baseline study was conducted in 2020 to which the identified provider responsiveness score was at 93%, while at the hospital level, pilot testing of a client satisfaction tool is still ongoing. Albeit the out-of-pocket spending is at 53.9 last 2018, early win is noted in the relatively high performance or high percentage of population who have spent less than 10% of their household income on health as captured in a 2015 baseline study. This strategy map is translated of the F1 Plus sectoral strategy into organizational level commitments. The DOH's strategic focus is to catalyze the transformation of local health systems to province and citywide health systems while delivering its core and support functions aligned to the strategy. This diagram shows how each breakthrough impacts the F1 Plus pillars, labeled 1, 2, 3, and 4. Performance accountability is at the core of the department's strategy. DOH employees, as well as the department's relevant stakeholders, were compelled to contribute to the success of F1 Plus through setting of strategic targets and commitments in their scorecards. The department order on guidelines on the performance governance system and the use of the Office Performance Commitment and Review, or OPCR, as part of the cascading framework embedded the PGS principles in the performance management system of the department. Financing for the sustained investments for equitable healthcare, service delivery in providing wider access to essential healthcare, regulation to ensure high quality and affordable health products, devices, facilities, and services, governance in strengthening sectoral leadership, coordination, and support mechanisms for functional and people-centered health systems, performance accountability using management systems to drive transparency and responsiveness. As a background, Republic Act 11223, or the Universal Health Care Act, was signed into law on February 20, 2019. Thereafter, the DOH immediately embarked on the development of its implementing rules and regulations. The IRR development undertook an iterative and consultative process until October 10, 2019, when it was approved by the DOH Executive Committee as well as the PhilHealth Board. Starting November 2019, the DOH had embarked on disseminating the Uhc Act and its IRR to various stakeholders in various fora. To provide a roadmap for implementation, the Uhc Policy Agenda was developed. It includes the operational guidelines for the establishment of systems, processes, and mechanisms that would enable the effective implementation of the Uhc Act. The DOH also aligned its 2020 as well as its 2021 budget proposal to the requirements of the Uhc Act implementation. And lastly, Uhc Integration Sites were prepared through the provision of technical assistance on integration-related reforms. Since its effectivity, the DOH endeavored wide dissemination activities of the Uhc Act provisions and its IRR. A Uhc Act orientation was conducted in the House of Representatives on November 13, 2019. The same was also disseminated to all the DOH units and instrumentalities, as well as health partners during the 6th National Health Sector meeting that was held on December 8 to 10 in Metro Manila. Recently, just before the COVID pandemic, the Uhc Act and its IRR was presented in a Health Research Partners Forum during the National Health Sector Research Forum that was held in January 20 to 24 in Cagayan. In compliance to the provisions of the Uhc Act, the Uhc Policy Agenda was developed. It guides all the necessary instrumentalities of government like the Department of Health, PhilHealth, Professional Regulation Commission, and local government units, among others, in implementing the specific mandates that were respectively assigned to them by the law. The policy agenda is divided in 5 themes as provided for by the Uhc Act, namely, organization of the local health system, establishment of the primary care provider networks, service delivery packages, financing, and governance. Briefly, this is to summarize the Uhc Policy Agenda. According to the Health Policy and Systems Development Team Forward Plan, 70 to 80% of the UHC policies from the UHC Policy Agenda should be approved and published by the third and fourth quarters of 2020. The 20% of the remaining policies in the UHC Policy Agenda shall be approved and published by the first and second quarters of 2021. As of September 2, 2020, almost 50% of the UHC policies from the UHC Policy Agenda has already been approved and published. Shown here are the policies published and posted under the Local Health Systems pillar. All numbered policies have been published. Also shown here are the policies published and posted under the Service Delivery pillar. Numbered policies have been published, while policies without numbers are in various stages of development and approval. Also for financing are the policies published and posted under the Financing pillar. Numbered policies have been published, while policies without numbers are in various stages of development and approval. And same goes through with regulations and governance. The UHC Act also calls for establishment of new offices, creation of new committees, and expansion of existing bureaus. With this in mind, the DOH has prepared staffing proposals for new offices such as the Health Promotion Bureau and the Performance Monitoring and Strategy Management Division. New committees like the Health Technology Assessment Council Secretariat and expansion of the Health Facilities and Services Regulatory Bureau. All these proposals are currently with the Department of Budget and Management for their review and eventual approval. Also, with the advent of the passage of Republic Act 11332 or the Notifiable Disease Act, the expansion of the Epidemiology Bureau will be considered by the next budget proposal. UHC integration sites are currently being prepared. The local government units have informed the DOH of their intent to integrate. Thus, provision of technical and financial support to 58 UHC integration sites has been initiated. Specifically, they are composed of 9 highly urbanized cities and independent component cities and 49 provinces. To date, 25 UHC integration sites have a memorandum of understanding with the Department of Health. In preparing for the UHC integration sites, the DOH has undertaken the following. Our regional offices or the Centers for Health Development were directed to assist the UHC integration sites to form local UHC project management teams and will be responsible for localizing and implementing UHC and integration reforms. Financial and technical assistance were provided to these sites. Late last year, capacity building on strategic planning towards local health systems integration was conducted and attended by local health system planners and managers. Funds were also sub-allotted for the hiring of development management officers that would assist these sites and for conducting UHC-related governance and communication activities. This 2020, financial assistance has been provided for the hiring of additional UIS support staff. This was provided through the Local Health Systems Development Assistance in line item in the GAA. LGU response to COVID-19 fast-tracked the development of population-based services such as epidemiologic surveillance through the COVID Kaya and faster applications, health promotion, development of information and reporting systems, and the setting up of referral networks. The DOH, through the Health Human Resource Development Bureau, developed a registry of primary care workers. This database served as a reference in enrolling primary care workers to the primary care orientation course required for issuance of provisional certification in primary care upon its completion. As to the DOH Apex hospitals, the following gains have been noted. Service capability mapping of DOH hospitals for 16 identified specialties. Signed intent of DOH hospitals to become Apex hospitals or end referral centers. And DOH hospitals with strategic plans to develop identified specialties. Because of the COVID-19 pandemic, the DOH also realized that investment and development in health is needed to adequately respond to future health emergencies. The following strategies will be implemented to ensure seamless execution of UHC Act despite the new, better living situation brought about by the COVID-19 pandemic. Strengthening capacities of LGUs to implement population-based services and primary care and to respond readily to emerging threats and emergencies through more integrated health systems, including implementation of alternative modes of service delivery to comply to infection control standards and physical distancing. Improving health system capacities to adequately respond to health emergencies, particularly for emerging infections. Institutionalizing streamlined and digitized processes and mechanisms, emphasizing enhanced and more instantaneous data generation analytics. Maximizing multi-sectoral government engagement, whether it be private, civil society, other local and international partners, to manage multidimensional risks arising from public health emergencies. And instilling more responsible community behavior through enhanced health promotion and health literacy program. Moving forward, the following activities shall also be done by the Department of Health. Approval and publication of remaining priority policies and those in the pipeline. Localization of the published policies in UHC Integration Sites. Ensuring adequate budgetary outlay for UHC staffing needs. Implementation of health laws and programs for COVID-19 response. The DOH puts UHC-related activities as one of the top priorities as it is essential in the operationalization of the UHC. This includes local health systems development and assistance, human resources for health deployment, facility enhancement program of primary care facilities, establishment of health information technology, and health sector research development plans. Lastly, the following are the priorities of the DOH. Alongside UHC policy implementation are policies related to health systems resilience for emerging infectious diseases and or pandemics. COVID-19 initiatives and resilience will mainly focus on the operations of national reference laboratories, international health policy development and cooperation, regulation of health establishments and products, and provision of quarantine services and international health surveillance. Other health laws were passed, such as the Cancer Law, Malasakit Law, HIV/AIDS Law, the Notifiable Diseases Law, and more. DOH stresses the importance of these health legislations and their need for implementation because they will impact the prevention and control of non-communicable diseases operation of DOH hospitals and much needed medical assistance by indigent patients. Likewise, policies covering urgent concerns such as rabies control, HFEP for primary care, and the non-COVID-19 facilities operations of blood centers and National Voluntary Blood Services Program and operations of drug abuse treatment and rehabilitation centers shall be prioritized. Meanwhile, set of policies focusing more on the operations of the department covering human resources for health, institutional capacity management, health facility policy, and plan development, among others, are in the pipeline. Maraming salamat po.
Thank you so much, Sir Ken. Good morning po. So now we open the floor or the platform for questions, and Sir Ken will be here to answer your questions po. So again, please use the chat box on the right side of your screen for any questions or comments related to Sir Ken's presentation. So Sir Ken, there is one question already lined up. So universal healthcare is a recent flagship reform of the Department of Health. So how did the COVID-19 pandemic affect the implementation of UHC, and does the DOH have any contingency plans to address this? So that's the first question.
Well, thank you very much. Well, as we all know, the pandemic came in untimely. But if I may just say, this also was a good event. Why? Because it also facilitated many of the processes that we had for universal healthcare. For example, as mentioned in the presentation, we had provided a good information system. We have provided facilitation of positions specifically for the priority areas under the universal healthcare. So these were submitted to already to the Department of Budget and Management. Of course, well, digitizing information, health promotion, surveillance is very important, which is also an important part of the universal healthcare, and also health emergency response. So many of the provisions in the UHC law were in fact facilitated because of the COVID event.
Thank you, sir. So I guess it's nice to know that the COVID-19 did not really derail the full implementation of UHC, but in fact, we are actually more aggressive towards accelerating in delivering UHC po for the Filipino people. So the next question po, related to that is, what are the key benefits or the tangible benefits that every Filipino can enjoy po from the implementation of UHC?
Well, the benefit of all Filipinos, of course, is getting better health. As we looked at the strategy map, it says better health for all Filipinos in Asia Pacific by 2022 and in Asia by 2040, and that's how we see universal healthcare. So health for every Filipino, that's the basic message.
Okay, thank you po, sir. So from Ms. Leonido Olobia, there's no disclosed or institutional affiliation. His question is, if UHC is implemented next year, how is the budget allocation for specific health programs at the DOH Centers for Health Development level? Is it still the same daw po?
Well, we have first for 2020, of course, we have allocated funds for UHC, some of which, of course, we all know were repurposed for COVID-19, but we still maintained budgets for UHC. But for 2021, we have enough allocations for UHC, and we saw to it that there's a separate allocation for COVID-19. So it's a separate, we saw to it that funds for UHC is appropriate for 2021 as we go through the full implementation of UHC.
Okay, so connected po to that, sir, I guess this is the last question. If we're not seeing any other new questions being recorded sa chat box. So in line with that, how did COVID-19 change the health program plan daw po of the DOH, or was there any change at all, or baka wala naman po?
Well, we have our usual programs, and we continue on the programs of the Department of Health. Of course, we report post, as I said earlier, we report post some of our activities and funds for COVID-19. But as a whole, while we fervently work for COVID-19, we haven't forgotten other programs of the Department of Health.
That is duly noted, sir. Thank you so much. So with there's no other questions coming in from the chat box, I guess we're done, Sir Ken. So thank you, Sir Ken, for your enlightening presentation on the health sector performance. And again, we would like to express our appreciation to our esteemed delegates for gracing us with their time as we celebrate the 18th National Health Research Forum for Action. So let us now proceed to the research presentations. We will be joined today by 3 esteemed researchers. Each presenter will be given exactly 20 minutes to discuss their studies. After each presentation, another 10 minutes will be given to our panel of reactors to raise a few points, and then another 10 minutes will be allotted for the question and answer portion from the questions that we will collate from the chat box. So for the first study, we will be joined by Dr. Antonio Dans. Dr. Dans is a current professor in the University of the Philippines College of Medicine. He is also the head of the Medical Research Unit in UPPGH. Dr. Dans is a recipient of Award for Continuing Excellence in Services, Metrobank Foundation Academician, and National Academy of Science and Technology. Now, Dr. Dans will present his study entitled Effectiveness of Preventions for COVID-19 Response.
Thank you, Francis. Just let me get my slide started. Good afternoon, everyone. Thank you to the NHRFA for inviting me to talk to you today. The work I'll be presenting comes from joint work we did with the Asian Institute of Management, specifically Professor Herrera. I'm going to talk on the effectiveness of preventive measures for COVID-19 and show you how we manage the data there. And I'm going to use guidelines for mass gatherings and recreational activities to show how this data might be used in various settings. So when we were requested by the IATF to propose guidelines on mass gatherings, we had the following objectives: to mitigate the risk of transmission, specifically protecting vulnerable and high-risk populations and settings. The target was to maintain healthcare and public health capacity demands below critical levels. So, kailangan maalagaan pa natin ang mga may sakit. And then increase social and economic activity with appropriate conditions and controls in place. And finally, to undertake continuous monitoring of impact and monitoring of new evidence as they arise, because so much comes up in so little time during this pandemic. We actually have one article coming out every 5 minutes. I've never seen such an information boom in any other condition in the past. And of course, lastly, frequent and transparent communication. Has my slides disappeared? Hello?
Dr. Dan, we can still hear you po,
You can
Dr.
still hear
Dan.
me? Can you still see my slides?
Yes, sir. We can still see
good.
your slides.
So the principles on guidelines on mass gatherings included Well, we wanted evidence-based decision-making, accountability and transparency, and then, of course, flexibility and proportionality. So public health measures should be relaxed based on the level of threat and in a controlled and phased manner. So here are some of the determinants of transmission rate that we had to consider. So transmission rate, we consider the modes of transmission: airborne, droplet, and fomites, which I think is now widely accepted. This is the reference for that, and there are many references for these modes of transmission. Duration of exposure is important. Studies showing that the shorter the exposure, the better, and some researchers have placed the limit at 30 minutes. Distance also important. The further, the better. And 1 meter set by some authors. Here, this is the reference for these numbers. And severity of disease, this is a recent finding which I think everyone should listen to very carefully. Severity of disease, this was published just a few weeks ago at the Annals of Internal Medicine. It's one of the determinants of transmission rate. When it's severe disease, the attack rate is about 6.2% of contacts. For moderate, it's 5.6. For mild, it's 3.3. And for asymptomatic disease, the attack rate is only 7.3%, or 1/10 of mild disease. And this should, I hope, allay the paranoia surrounding asymptomatic transmission. No? It does happen, but it is much, much, much lower than mild, moderate, and severe transmission. And perhaps we should recognize this when thinking about protective measures in the public. So the prinking process used to develop guidelines. We assessed the need for the recreational or public activity, assess the risk level of that activity, identify applicable interventions, adjust preventive measures to the level of risk, and gradually loosen as risk declines, and retain certain preventive interventions under the new normal. No? So the guidelines are provided based on the level of health risk. Now, they're roughly analogous to the level of quarantine, but we're recommending that the particular guidelines respond primarily to health risk. This is because these recreational activities are not critical for ensuring availability of critical supply chains and services. We also recommend that the health risk assessment be expanded beyond the current case doubling time and critical care facility utilization. No? This is usually what we use. ECQ, MECQ, GCQ, and MGCQ, we use the case doubling time and the critical care utilization rate with some modifiers. No? And we think that one of the modifiers, health system capacity, should address closely the number of healthcare workers available, so healthcare worker density. This is the main reference for the strategies we'll be showing, no? On some of the measures: physical distancing, face masks, and face shields or eye protection. No? So this is how they did this study, just to show you how thorough it was. No? They reviewed 17,000 records or studies from using the standard database searches from Medline, PubMed, CINAHL, Cochrane, etc. But they also did the other strategies, such as looking at registries, hand searching, and screening the cross-references of the studies. No? From these almost 30,000 articles, they read the titles and found the 20,000 records after the duplicates were removed, so some studies were published twice. And reading these 20,000 titles, they removed 19,000 more and found the 600 articles that would possibly address the issue of protection. And from here, I removed another 432 articles, wrong design, wrong outcomes. They wanted to look at transmission rates, wrong population, etc. Other reasons for excluding it. To find the 44 comparative studies that would inform recommendations on physical distancing, face masks, and eye protection. So this is a difficult process. As I mentioned earlier, one article comes out every 5 minutes. There's 60,000 publications on COVID-19 related technology in just the past 8 months, which is around one article every 5 minutes. So actually, any recommendation we have on technology during this crisis should undergo this thorough process. So, for example, they found that, so this is the relative risk, 0.24, the ratio of transmission in patients wearing face shields compared to transmission rate among patients or people not wearing face shields. The ratio was about 0.24 or 1/4, which meant a 76% reduction in transmission. That's during the study on MERS. During SARS, they found similar, a 34 relative risk or a 66% reduction. And for COVID, really no thorough studies on that yet. So here's the estimated effect of the preventive interventions. 1 meter distancing leads to 82% reduction of this in this study, and 2 meters is better. That's 91% reduction, and 3 meters is best with 96% reduction. For every additional meter, you reduce the remaining risk by about 50%. So the further, the better. An N95 mask confers 96% reduction. A non-N95 mask, which is what we allow the public to wear because of scarcity of resources, leads to 67% reduction. Now, some nuances here, no? These studies are independent. The studies on distancing, yes, 3 better than 2, better than 1 meter. And the studies on masks, yes, and 95 better than none, and 95 in general. And there are also studies on face shields and open air, which I'll show you later. So the interventions should not be compared to each other. Distancing, you cannot say it's better than non-N95 masks, no? Because that was not the purpose of these studies. And effectiveness is a function of compliance. So even if you say 3 meter distancing, that meets various levels of compliance. And last, estimation of combined effects assumes independence of the mechanism of action. For example, distancing shouldn't affect the effectivity of masks, no? They should not make masks less effective. So we can combine the effect. 1 meter distancing is 82% reduction, and a non-N95 mask, the combined effect is 94% reduction. If you do 2 meters, it's even better. With the non-N95 mask, it's 97% reduction. In areas where you can't distance, a face shield, as I showed, leads to 78% reduction. So face shield with a non-N95 mask leads to a 93% reduction in transmission. And face shield with a non-N95 mask with 1 meter distancing leads to 99% reduction. This is an interesting study. I'll show you the reference later. Open air activities lead to 95% reduction in transmission. So eating in a restaurant and closed space as opposed to eating in open air leads to a 95% reduction in transmission rate. So in open air with an non-N95 mask, that's a 98% reduction in transmission. Of course, we should not forget the other strategies. If you isolate yourself when you're sick or quarantine if you're exposed, then you are unlikely to transmit to anyone. So we made a list of different combinations. And the point here, I think, is if you look at the last column, even with various combinations, there is a residual risk. So even at the top here, 7.26%, that's a high residual risk. Even 1% is a residual risk. Is important because remember, this whole pandemic started with one person or very few people entering the country. So one can easily multiply. And so we should use as many strategies as possible given a particular venue. So when we apply these two types of gatherings, we divided them into two types. The columns are recreational activities, and on the right you have social and other mass gatherings. And then we divided them into outdoor and indoor settings because of recent data showing that that's important. So recreational activities in general are lower risk than social and other mass gatherings. And outdoor is generally lower risk than indoor. And so we had recommendations for each of these four categories, which I will show quickly. This is the list of preventive interventions. So we considered hygiene, masks, face shields, distancing, limiting the number of people in a venue, thermal screening, using a QR code for contact tracing, physical barriers, sanitation, so cleaning the environment, provision of ventilation, addressing vulnerable population, and duration of the activity. So for the first category, recreational activities outdoor, we classified it into Group A, where physical distancing is easy to maintain, such as jogging and biking. Group B, physical distancing is moderately easy to maintain, such as tennis. And physical distancing, Group C, difficult to maintain, such as in contact sports. And then these are the various levels of quarantine. You might roughly say it corresponds to ECQ, modified ECQ, GCQ, modified GCQ, and the new normal. So for the low risk activities, so we allowed with restrictions earlier. So specifically 1, 2, and 4 are hygiene, masks, and distancing. And for Group B, physical distancing started later. And for Group C, the high risk started much later with the addition of sanitation. For activities such as sports and again, but indoor, we have more restrictions and added 6, 9, and 10, which is screening, sanitation, provision of ventilation, and facilities for vulnerable populations. And for social gatherings now, low risk, outdoor, again, earlier with a lot of interventions, hygiene mask, physical distancing, shield, limiting the number of people, but starting early. You know? For mass gatherings with public events with many participants and now with more interaction, starting later. And the highest risk is public events with activities where there's a lot of interaction. And that started later. So, for example, weddings, etc. And lastly, gatherings indoor, which is higher risk. Again, the interventions are started earlier. So that's how we use the different data on preventive measures. Now, just to end with this slide, because I think these are the 4 landmark studies that guide us. If you want to take a shot of any of the slides, this would be the one, because this would lead you to the many of the references I showed. So that's my last slide. Thank you very much for your attention.
Thank you very much, Dr. Dance. And now we open the floor for the panel of reactors. So our first reactor for this first presentation is Dr. Alfredo Mahar Francisco A. Lagmay. Dr. Lagmay is the Executive Director of UP Resilience Institute and the Director of UP NOAA Center. He is also a professor in the National Institute of Geological Sciences in UP Diliman. Dr. Lagmay is also a recipient of the Premies Medal from the European Geosciences Union and also an academician from the National Academy of Science and Technology. Welcome to the webinar, Dr. Lagmay.
Hello, good morning, everybody. Is my audio heard by everybody? Am I okay to proceed?
Yes, Dr. Lagmay, may you please turn on your
Hello?
camera? Hello, sir. Good morning. Sir, kindly turn your camera on po. Thank you, sir. Okay na po.
Okay. All right. Thank you very much. Thank you very much, Dr. Dance. I respect you a lot. And in fact, I idolize everything that you do, especially with helping the Filipino people. And thank you very much for doing all of the research work on COVID-19 regarding this pandemic. You say that there's about one article that comes out on the pandemic every 5 minutes. And on behalf of the Filipino people, I know that this is a lot of work. You spend a lot of your time, private time included, for doing this service for our country. And thank you very much for doing the presentation on the proposals for social distancing and other guidelines for mass gatherings. The objectives of the guidelines, as instructed by the government for your office and for your group, was very clearly stated. That is to mitigate the risk of increased transmission, protect the vulnerable and high-risk populations, maintain the healthcare and public health capacity, increase social and economic activity. We know that this is very important because it's not only the health considerations, we have to balance it with economic activity, which is highly important in boosting the economy. Monitor impacts and new evidence, and of course, the communication, which is a critical part in trying to curb the rise of infections from SARS-CoV-2. And we really appreciate also the principles and guidelines that you took in trying to execute all of these objectives, that there's going to be science and evidence-based decision-making, coordination and collaboration, accountability and transparency, flexibility and proportionality. We know that the metrics change all the time, over time, and it's necessary to be flexible and to adjust depending on the current situation. Later on, I would like probably to ask questions on science and evidence-based decision-making. You have presented a lot. With regard to the coordination and collaboration, it's important that it's a whole of society approach. And if we were to talk about science and evidence-based decision-making, maybe Dr. Dance can comment about the data sets that are released for reproducibility of the science, because the reproducibility is a foundation of what science is. and that builds trust, and trust is important in communication. Maybe Dr. Dance can comment on that, since it was presented in as the principles for guidelines on easing mass gatherings as presented. There was also the mention about preventive interventions, basically focusing on the physical distancing measures and what categories of community quarantine these 10 preventive measures, or sorry, I think there was a list of 11 preventive measures that would be applicable for each category of community quarantine, from enhanced community quarantine to modified enhanced community quarantine to general community quarantine and modified general community quarantine until we return to the new normal. There were certain limitations on the preventive measures that are applicable for each of these categories, and perhaps Dr. Dance could comment on why there are limitations only for certain GCQs, considering that we have ECQs and MGCQs. These are categories that are sometimes controversial and would be a decision that government makes. And also considering that these preventive measures, like for example, hygiene, masks, shields, distancing, screening, the use of QR code, barriers, sanitation, and so on and so forth, are not really uh, that difficult to implement, even with all the community quarantine categories. So why not have them all as health precautionary measures in all of the community quarantine categories? Remember that sometime in August, doctors were talking about the overwhelming of the hospital care system. I attended, I saw Dr. Dance group seminar of the group of medical professionals arguing that there be a break and a return to either ECQ or MECQ. And that was eventually granted sometime in August, and it was lifted to many parts of the Philippines into GCQ. So I was just wondering why all of these 11 preventive interventions need to be taken out in some of the categories of community quarantine, when in fact, like for example, shields or screening or the use of QR codes are not difficult, not really that difficult to implement, including the barriers and sanitation. Uh, I guess these are normal things that should be really done. So why take it out? Especially that although we have been seeing the lowering of the time varying reproduction number, the RT has been going down and has remained stable, more or less below 1 for several days already. But nonetheless, we still have a lot of active cases. So why take out the rest when they could be helpful as a health intervention measure? These are going to be part of the minimum health standards, and it would not take much really to have them all still in place. And then there was also a presentation, or part of the presentation was about recreational activities and social and mass gatherings. These are very, very important. Thank you very much for highlighting this. Of course, mental health is very important. And there was mention also of the critical activities that need to be limited. I guess my sense is that the GCQ or whatever category it is, whether it's lowered down, since we're still high up there compared to other Southeast Asian nations, we're almost the same as Indonesia. Why limit the why not limit the activities, especially that it can help still or further lower the transmission rate. I mean, all of these measures that we are doing, observing the minimum health standards, are very, very important, and they would really help, as discussed by Dr. Dance, that it would help in increasing the doubling time and lowering the reproductive time varying reproductive number. So that's good. I was just wondering why some basic things, if we were able to survive during the MGCQ not to party, if we were able to survive not drinking with friends, if we were able to survive not doing the extra things that we needed to do during the ECQ, why not do it now, especially that we are still in the midst of the height of the pandemic. Maybe a comment or two on that. But otherwise, thank you very much. That was an excellent presentation, Dr. Dance. We really appreciate it. And we really appreciate all of your efforts on trying to limit the transmission of SARS-CoV-2 and the spread of the disease that has really brought all of the Filipinos down for several months already. There are a lot of issues, more than just health, economic. There are also mental health issues, and it's really getting very, very difficult to proceed. And all of us got surprised by this COVID-19. I guess anticipation was very important. It highlighted the need for improving our healthcare system. But I guess the bottom line for all of these talk is, have we been able to limit the overwhelming of the hospital care system? So I guess that's the bottom line metric. Are the frontliners overwhelmed? Do we have enough critical facilities still to accommodate all of the COVID-19 infected people? But thank you very much again. That was an excellent talk. We need the people to hear more about all of these minimum health standards, especially the physical distancing. I've been going around and I've been seeing people wearing masks, but their masks are exposing their noses. So I've been seeing people really wanting to talk to people. They want to go close to people, especially if they know them or their friends. Communication or education is highly important. That needs to be beefed up. I would really exert effort to echo everything that you have just presented, because what you have presented to all of us is really I would say, the last resort. If everything else fails, including the contact tracing, which I would comment has been too late in the game. Baguio was good at it, later on Cebu, but on a nationwide scale, I sense that there was some kind of failure in the contact tracing and the isolation. Although testing, we have ramped it up to incredible levels, to very high levels, and that was good. That was a good preparation for the ECQ. It gave us time to have more tests, but during that process, I would like to comment that we were weak on the contact tracing. And as a last resort, all of these intervention measures that you are discussing, that you are saying, are very important, and they need to be heard by each and every Filipino so as to be successful in our COVID-19 prevention efforts. Thank you very much, Dr. Dance.
Thank you, Mahar. I can answer quickly, Francis. So
Yes,
first,
sir.
thank you for that kind words, Mahar. I'm also a fan of
Thank
your
you.
disaster response. Your involvement in disaster response in the past. So we have a mutual admiration society. I apologize for not sending you the slides, Mahar, kasi by some freak of an accident, I have 3 lectures today. So I just couldn't make the slides available soon enough for you. So I apologize for that. About your specific questions, first on the reproducibility of our pandemic data, no, our statistics, and the trust in it. On one hand, we see a lot of noise, di ba? Naiiba yung sex, yung patay nabubuhay, yung nabuhay namatay. So the data's continually being cleaned up. So it's a dirty database. But I also approach it with some level of understanding because this is a live database, and having worked with research data, I know that live cleaning is very difficult and sometimes impossible. So I appreciate that it is being cleaned. There are a lot of system problems that need to be solved. For example, a lot of the process is still manual. Hindi totally electronic. So nahuhuli talaga tayo. And these are system problems that need to be solved. And we are in long discussions with the IT on how to fully automate the process. About limitations of various preventive measures, tama ka, bakit nga ba hindi gamitin sa lahat? Actually, gagamitin naman namin sa lahat yung various interventions kung feasible. For example, in sports, feasible naman face mask. We will use it all throughout. And the main recommendation was, when do we open up to outdoor sports? No? We proposed that early on. Baka MECQ, pwede na. Kasi in fact, in many countries, during their full quarantine, they allowed outdoor sports activities like jogging alone, biking alone, or walking alone. Since the risk of transmission is very low, if you're wearing a mask, if you add a shield and implement physical distancing. Also, at various stages, we had some slight differences. Kunwari, parami ng tao ang allowed in mass gatherings, 10, 20, 50 at MGCQ. And this is because the modeling done by AIM showed that the reproductive factor had a lot to do with the number of people. Akala ko noon percentage lang yan eh. But actually, the more people, even if you maintain them at 1 meter apart or 2 meters apart, the more people you have in a gathering, the bigger the risk of transmission. Yeah, so right, once an activity is allowed, it's almost the same all throughout. Once you allow people to go to movies, the same preventive measures will be allowed all throughout. So why not? I think the more difficult question is why not allow it until the pandemic is over? Since
Yes.
recreational, non-essential activities, I think that's the whole concept of the hammer and the dance. Diba? The dance is, are you ready to dance? Are you ready to go out with the virus around you and resume your normal activities? Because these activities, like socializing, meeting your relatives, for me, being with my grandchildren, these are not essential to survival, but they are essential to life. No? And life is not just about survival. And I think that at some point, maybe at MGCQ, we should be allowing these social activities because that's what life is all about. And we can lighten gradually if we are ready to dance and implement these measures. The most difficult question, or the last question was, have we succeeded in the last month in re-strategizing our pandemic control? The hospitals are less full today, Mahar. May vacancy na actually sa PGH. Dati, last August 1, 16 ang line. But having said that, it's too early to declare that we're controlling it, because as we lighten quarantine measures, that's where we're going to see, did we prepare enough? Are we ready to dance? So we need to observe over the next 2 to 4 weeks, which is crucial. As we lightened quarantine, were we able to control it? No? So important yon, the hammer and the dance, and these protective measures that I talked about. They're all about dancing with the virus. Thank you.
Thank you very much, Dr. Dance.
Thank you, Mahar.
Thank you.
Thank you, Dr. Maya and Dr. Dan. So now we will open the floor for the Q&A from the collated questions raised by our online participants in the chat box. So Dr. Dan and Dr. Lagay, first question is from Mr. Vicente Salas. One determinant of transmission is intensity of contacts. The more contacts you have, the greater the risk. I was wondering if you considered this, as it was not one of the factors in your slide of determinants.
Yeah, so quickly lang, if contact is actually distance and time. So if intensity of contact, so close contact is defined as less than 1 meter more than 30 minutes. And the closer you are, if you actually have physical contact, and the longer you stay together, for example, if you live with that person or are actually caring for that person, then that's intensity of contact. So it's a combination of duration and distance.
Okay, thank you for that. So the next question is, how do we further encourage people to practice preventive measures and protect the public from infection?
Okay, so what the Healthcare Profession Alliance Against COVID, HPAC, is doing, we were the group that called for a timeout last August 1, is trying to change the message, Francis. Wag na yung takutan, gamitin ng talino, wag yung pananakot, at gamitin yung dapat may hope eh. We should have positive messages, no? Pag-asa dapat ang binibigay natin sa tao. Hindi dapat inspire them. Do not scare them, inspire them na kaya natin to. And one of the messages, abangan sana natin on September 14, we are launching an information campaign along those lines, which aims to prepare Filipinos for Christmas this year. No, isipin natin yung Pasko. Gawin natin lahat para maging as close to normal ang ating Pasko. Kung hindi man tayo magkasama, sana makaya natin by then. Pero kung hindi man tayo magkatabi, sana buhay at malusog ang mga mahal natin sa buhay. No? So this is something we are launching in January 14 with some creatives September 14. So sana abangan ng publiko yung lalabas na information campaign.
Can I comment? Can I comment on what Dr.
Dan said? The importance of framing the narrative. Sige. Yes po.
Can I comment?
Yes, Mahar, go ahead.
Yes, I totally agree with that message of hope. No? In fact, during the earlier meetings of the IATF sub-TWG, in preparing for all of these materials for communication, we emphasize that all messages should be goal-oriented and should have messages of hope.
Mhm.
No, because it has a bearing on the psyche of the Filipino people and how they would respond. It's very, very important that that kind of communication be relayed, because it, it's a feedback mechanism.
Yes.
Depending on the policy making, there would be some kind of influence on the turn of events, and depending on the communication, it has influence on the turn of events. And
Agree.
one of the critical ways to do it is to get it to be goal oriented, to hype up everybody
Yes.
to fight this war or to fight this battle. So that's a very important point, I think, that was raised.
Yes. So hindi takot, talino, hindi parusa, pag-asa.
Yan.
No. Kaya natin 'to.
Yeah, so again, thank you for raising actually that point po, or that insight on really being strategic and framing the narrative, because it will really affect like how people will respond. So that's actually an important takeaway po. So another question is from Mr. Daryl Valiente from PJGMRMCs. Is there a benefit in documenting those who visit establishment in terms of contact tracing?
I think so. You know, alam mo yung contact tracing dapat hindi natin ginagawa pag na-expose na yung patient. Dapat prepared tayo for contact tracing even before people get exposed. So, ang ganda sana if we had the national ID system around, madali mag-contact trace, may information ka na on everyone. Pero not having that, I think people should be registering already. And merong mga proposed systems. There are apps, different apps being proposed for it. I think what app we will use para madali ka i-contact trace is less important than that we all use the same thing or something that things that can communicate with each other. Kasi ngayon, kanya-kanya eh. Each institution has its own app. No? Mga, kunwari, Starbucks has its app and some yung kung ano-ano yung app for contact tracing. And every time you enter an institution, you have to fill it up separately. So we need to come up with some standardized way to, kunwari, kung may QR code tayo lahat or ID, edi isa-scan na lang para nandun na lahat ng information na kailangan. So, key is to automate the information that leads to contact tracing.
Thank you, Dr. Dance and Dr. Lagway. So that is the last question before the break. So thank you, Dr. Dance and Dr. Lagway, for joining us and for sharing your expertise with us today.
Thank you, everyone.
Thank
Thank you
you.
for your attention.
Thank you very much.
Thank you.
So, ladies and gentlemen, we will be back shortly after a short break. Thank you.
Ngayong mas naintindihan na natin kung ano nga ba ang expanded testing, importante namang malaman natin ang pinagkaiba ng RT-PCR at Rapid Antibody Tests o RATs. Ang Reverse Transcription Polymerase Chain Reaction o RT-PCR ang ginagamit na confirmatory test para sa COVID-19 dahil kaya nitong matukoy ang virus sa katawan ng pasyente. Habang ang Rapid Antibody Test o RAT ang siyang tumutukoy kung may nabuo ng antibodies na panlaban sa virus sa katawan ng pasyente. Kaya naman sa dalawang test, Polymerase Chain Reaction o RT-PCR sa pagkumpirma ng COVID-19 cases. Ito ang ginagamit natin ngayon sa expanded testing. Pero paano nga ba
Nasistress ka na ba? Nagpapanik o natatakot dahil sa COVID-19? Normal lang ang ganitong mga reaksyon sa ngayon. Pero may magagawa ka para mapagtagumpayan ang sitwasyon na ito. Ituloy lang ang pangangamusta sa mga kamag-anak at kaibigan gamit ang text, tawag, o video. Tiyakin na ang mga bata ay ligtas at nasa maayos na kalagayan. Kung ikaw ay nasa stress na, huwag itong ibaling sa kanila. Tandaan, anuman ang iyong reaksyon ay maaaring makaapekto sa kanilang emosyon. Gawin sa bahay ang mga nakasanayan upang hindi mabagot o mabalisa sa panahong ito. Basta siguruhing protektado ka laban sa COVID-19. Magdala ng good vibes sa bahay. Sa wastong pag-iingat, ang virus hindi kakalat. COVID-19, kayang-kaya nating tapusin.
Okay, so welcome back, everyone. For the second study or the second presentation for this morning, we will be joined by Ms. Megan Battle. So Ms. Battle is currently the Associate Director and Southeast Asia Lead of ID Insight Philippines. She was also invited to be the resource person in the AVPN Southeast Asia Summit, titled Impact Evaluation Workshop. Ms. Battle is also a recipient of Summer Scholarship at Johns Hopkins School of Public Health. Now she will present the study entitled ID Insight Parañaque COVID-19 KAP Study. So good morning and welcome to the webinar, Ms. Battle.
Thank you. You can hear me okay?
Yes, so you can proceed.
First, I would just like to say thank you so much to colleagues in DOH and Ateneo and for organizing and inviting me to present on behalf of my colleagues at ID Insight. So I'm really pleased to be here today. So I'm going to be sharing a little bit today about the work that we did, a study that we did recently in Parañaque in the spring, and sharing what we found about knowledge, attitudes, and practices about COVID-19 under lockdown, and what the implications were for policy response by Parañaque City Health Office, as well as the City Council and the Mayor. First, though, I'll tell you just quickly who I am and what ID Insight does. So we're a global research organization. We work with policymakers, government, foundation, NGOs to help them generate and use evidence for decision making. So really what we do is we think about, as Dr. Dans mentioned, there's so many studies coming out about COVID all the time. And from our side, the work that we do is coming directly from to answer the questions of policymakers. So in the case of the study that I'm going to share today, we were contacted by Dr. Olga Vertusio, who's the city health officer in Parañaque, who said, we have some really pressing questions around how to best be messaging about COVID-19. What do people need to know? And especially around the different services and economic support that the city was giving. So with that in mind, we wanted to help them answer their pressing questions. And that's really what ID Insight does with our research around the world. So This study was conducted in April and May. As you know, COVID-19 had already become quite an issue in the Philippines by then. And we were really thinking, especially in urban areas at that point, about the dual challenges of infection risk and income loss. And so we conducted this survey to help the city understand what we call CAP, knowledge, attitudes, and practices on COVID-19, as well as a few other topics. So non-COVID health concerns. I know that we're all really thinking a lot these days about what are the challenges for vaccination, for routine healthcare, for maternal health care during the lockdown, and then the socioeconomic effects of the lockdown. We were really focused on giving actionable recommendations coming out of this survey. So just quickly, I want to highlight the three key findings, since we won't have time to go into all of them in depth, and what the recommendations were. The first one was that we found that folks were really, really well acquainted with the idea of staying at home. And that made a lot of sense. They were in or coming right out of lockdown when we spoke to them. So they knew, like, if I stay at home, my family and I will be safe. And that's really great. It meant that they were staying home and following the quarantine as much as they could to a large extent. But what it also meant was that they weren't necessarily sure about how to protect themselves. So all those different measures that Dr. Duns was talking about, they weren't as familiar with the other hygienic protection measures that they should take. And so we were worried, okay, as quarantine restrictions ease up, will people know how to protect themselves in public? Again, this study was done several months ago, so I imagine that a lot has changed for this population since then. But at the time, our recommendation was, okay, we really need to make sure that people are learning about what hygienic protection measures they should take when they leave home. The second one that we found was that there was good awareness of symptoms and how and when to seek healthcare. But there were challenges around a few key points. And the one that I'm going to point out the most is around difficulty breathing. So people were really well aware that fever and cough were symptoms of COVID-19, but they were not as aware that difficulty breathing was a major challenge or that it should require them to immediately seek medical care. And so if people don't know that that's a symptom of COVID-19, that's obviously a major issue, since it's one that should immediately cause us to seek medical care. And so that was a big recommendation for us coming out of this, was that the City Health Office of Parañaque should be putting out communications around difficulty breathing or shortness of breath as a symptom of COVID-19 that should prompt immediate response. And what we also found was that the majority of the population that we surveyed had lost income in that time, but that less than a quarter had received cash relief. So we were recommending also to strengthen economic support to families, and particularly with disbursements of cash relief, in addition to the food relief, which many families had already received. So I want to just tell you briefly about how we generated the sample and who we're talking about when we say these respondents, because this is a pretty non-traditional way of generating a sample. So in order to do a representative survey, you need to have a list of all the folks that you want to be sampling from. And in this case, we needed lists of phone numbers that were up to date. And that's really, really hard to find in the Philippines right now for a specific geographic area. So knowing what we did about how much all of us in the Philippines use Facebook so much, we actually ran a series of ads on Facebook, targeted low-income residents in Parañaque, and you can see an example of this here on the slide, telling them, please participate in our survey. You can receive 50 pesos of load. And then we did a random selection of the folks who responded, and our final sample, you can see, is represented here in this box on the right-hand side. So what we found actually was that our sample was very comparable to Metro Manila population. It was slightly more female and slightly younger. We did use information from the labor force survey to create comparable groups. And so, you know, the people who responded to our ads skewed even more female and even younger, but we were able to oversample from specific groups, especially older people and men, to develop a sample that resembled those of Metro Manila. But we want to be, you can also see that the distribution around barangays was quite similar. We want to be really careful and cautious here, though, to say that this sample does not represent all people from Parañaque. What it represents is people who are highly online, who have phones, and who could use extra money. So in the case of the Parañaque group that we were targeting, we think this actually is like pretty close to the larger Parañaque community, and that's why we felt comfortable using this method. But there's obviously places where this method would not be applicable. And so we just want to be really upfront about the limitations of the respondents that we spoke to and their generalizability. So this study took place just over a few weeks. So it was really, really rapid in order to generate results really quickly, in order to share the findings with the Parañaque city leaders and help them with their response. I'm going to jump into our key findings. So what we found was that generally 92% of respondents claimed that family members had not been in contact with anyone outside their home in the last week, other than for essential purposes. We obviously want to caveat this. There's like a real role for social desirability bias. Respondents are probably more likely to tell us what they think they should do. But what we were really interested here is that, one, they all knew that they should stay home. So that's a real win for the public campaigns around quarantine. And then what we wanted to also highlight is digging into what are the reasons for the folks that said that they couldn't do that. Why did they say that they actually, what were those challenges coming from? And the two biggest ones were to work and to find money for food, or just to find food directly. The respondents also expressed economic and food security difficulties. You know, this felt really, really challenging to hear just how dramatic the economic difficulties were for these families. The average weekly income declined by 75% over this time. And we found that food scarcity had dramatically increased, had more than quadrupled. And that they were also struggling to meet other basic needs in some cases, so access to medicine, hygiene products, and childcare products. So they also were kind of concerned what happens if the quarantine is extended. And obviously we know several months later that this has happened, and we can expect that in many cases this has gotten even more challenging for the respondents of the survey and other their peers in Parañaque. So at the time of this survey, most of the respondents had not received have received food relief from the government, but not cash relief. So food relief respondent was extremely high. So, I mean, obviously this was a real priority from the Parañaque city government, and we were really, encouraged to learn that they had received food at home, and this was really helping with the food scarcity issues. But the cash relief was much lower than we had hoped or expected. And, in many cases, people didn't know why they weren't eligible or had actually been expecting to receive cash relief, but didn't receive it. And so, the distribution really did have room for improvement. The respondents just really were unclear about what the qualifications were to receive it, or, why it hadn't come through yet. So the key takeaways from the economic difficulties was that people were really, really struggling. Their livelihoods were impacted, their food security was heavily impacted, and that cash relief had not reached the people that hopefully it would be reaching in this time, and that the longer that quarantine went on, the more challenging that it would likely become. So I want to move now and talk about COVID-19, so knowledge, attitudes, and practices specifically around COVID-19. And so generally when we ask people, what symptoms do you know of COVID-19, they were able to name several symptoms. And fever and cough were quite frequently named, but as we mentioned, less than half named difficulty breathing as a symptom. And so this was even especially lesser known by older respondents, which made us even more concerned, knowing that they are the most likely to face severe symptoms of COVID-19. We also found, as I mentioned before, that staying home was the most known protection method, but that these ones that are outlined here in the yellow box really were not frequently mentioned. And it's funny, you'll see that even in the last few months, I don't know that we would be talking as frequently these days about not touching or disinfecting common surfaces or not touching other objects out in public. I think we've seen the more that we've learned about COVID in the last few months, we might prioritize some of these in different ways, as Dr. Dans was talking about. But we really saw opportunities for communications campaigns around other protection methods beyond staying at home, washing hands and wearing a mask, even though hand washing and mask wearing could have a lot of room for improvement as well. What we found about hand washing in particular when we asked about it was that nearly all of the respondents said that they had access to clean water and soap, hand sanitizer, or alcohol at home, but that they weren't necessarily sure about washing their hands frequently and using that to prevent COVID-19. And so this really helped us reach the conclusion that access to some of these hygiene practices, specifically hand washing, is more behavioral than structural, in that it's not that there's a massive issue with running water in Parañaque that's not keeping most people from washing their hands, at least not the people in our sample, but that the issue is that they're not knowing that they should wash their hands as frequently as they should be, and maybe they don't know about best practices around hand washing. So we're seeing a knowledge gap rather than a structural gap. So what we did find is that in many cases, respondents did know when to seek medical care, but that they're facing major challenges in doing so. And so what we see here is that for severe symptoms, they were able to say, yes, we would seek professional care. But that in other cases, they might, wait a few days, try alternative treatments. And what we found is that social distancing at home was also mentioned far less than observing at home. That again suggests that people feel really safe from COVID at home, which on the one hand is great if it's keeping them from going out, but could raise, some issues if people are going out, not protecting properly in public, and then coming home and feeling safe when potentially they could have brought the virus into the home from being outside. And so we also saw opportunities there for potentially, encouraging people to isolate at home or social distance at home in certain cases. So we also found that the prevalence of COVID-19 comorbidities in the respondents' families was moderate. You'll see here that especially high blood pressure, diabetes. Obviously, we know that these are risk factors for having a more severe case of COVID-19. And so we wanted to understand, how at risk was the population we're speaking with is. We want to speak really quickly. I know we're coming up on time, but I wanted to share a little bit about for folks who, needed treatment outside of COVID-19, were they able to receive it? And the ones who did say that they needed it, which was obviously a much smaller group. So again, our sample here is only 67 respondents. So I want to be cautious about, how many conclusions we can draw. But out of that, 66% did not receive the help or treatment that they needed. So that amounted to about 8% of all the families in our sample. That's a pretty large percentage from the total group that over the last, little bit had not been able to receive a medical care that they did need. And it really raises, concerns about people being able to stay healthy, especially now as we think about, okay, GCQ, MECQ, ECQ, all these different variations are going to be, we expect extended. And what can we do to ensure that folks are receiving the, primary health care that they need during the pandemic, and as these necessary measures are put in place to prevent the spread. And so, the key takeaways here is that there's a moderate prevalence of these comorbidities of COVID-19, but that the barriers primarily were around transportation inconvenience and also concerns about limited availability of medical professionals. So I'm going to quickly go into recommendations. I've been speaking to these a little bit as we've gone. And first, I want to talk about the recommendations for COVID-19. And so, complementing the stay-at-home order with hygienic protection measures. So really, continuing to encourage people to learn about social distancing, about hand washing at critical times, about protection measures inside the home. Just saying, okay, it's great if you are able to fully stay home, but that's probably not realistic for the long run, that everyone will not be leaving your house. And so being really thoughtful about the risk mitigation and the harm reduction that can happen when you do have to go out. We also wanted to guide appropriate medical seeking behavior and reporting for COVID-19. So in particular, emphasizing difficulty breathing as a severe symptom, and providing these health seeking protocols on exactly who to reach out to, when to seek medical care, where to seek it, and how to protect yourself when you are seeking medical care. For service delivery, because transportation did come up as a major barrier to folks accessing any kind of care, we were considering offering free transportation to hospitals at the time, and addressing fears around contracting COVID-19 in health facilities by, presenting and sharing the alternatives that do exist, and emphasizing the safety precautions in health facilities that can and should be taken. And then the last one, I didn't speak to this in the presentation just for shortage of time, but we did also ask several questions around stigma, around proper reporting, and why, whether people were comfortable reporting and who they would report to. And so we also had some recommendations on that. For non-COVID health concerns, these mirror very closely the recommendations for COVID concerns, actually. So guidelines around how and when to seek care, providing that alternative access and free transportation, and then addressing those fears of contracting COVID-19 in health facilities. For the economic support, what we wanted to really encourage Parañaque to take a closer look at is how to strengthen those disbursements of cash relief. So how to accelerate them, to make sure that the families that needed them they were reaching them, and to clarify eligibility so that people would know, okay, I am eligible, but I just have to fill out some forms. I haven't done that yet, or I'm not eligible for this reason and I understand why, or I'm supposed to have received the funds already and they haven't come and now I can follow up. So this was, really important to make sure that cash relief would be reaching the families that would need it. So just really quickly, we are working right now on a follow-up study with UNICEF and the Bureau of Health Promotion. So we're really excited to be running a similar study in sites all around the Philippines, using the same methodology to look at these different topic areas that you can see listed here. So several of them overlap with the study that we've already done, but there's some new ones as well around the trust levels of DOH, risk perception, and vaccine hesitancy. And the results from this will be directly feeding into communications campaigns that the Bureau of Health Promotion will be running. So TV, radio, and online campaigns. And so that they'll learn, directly from our survey, what do people need to know? What messages should we be sending? And then design their campaigns to address those. So I will pause there for a response and for questions, and really happy to hear what everyone thinks and to hopefully be able to answer your questions and hear your feedback.
Thank you so much, Ms. Battle. So before we open the floor for the panel reactors, I would just like to remind the audience or all those joining us today that the slide presentations will be emailed to you by the Secretariat at a later date. So rest assured that they will be sent to you through the email that you used when you registered in this session. So now we open the floor for our reactors. So the assigned reactor for the second presentation is Dr. John Hugh Wong. Dr. Wong is the chair and founder of Epimetrics Incorporated. He is currently an associate professor in the Ateneo School of Medicine and Public Health. Dr. Wong also serves as the chair of the DOH Drug Price Advisory Council and a consultant for the IATF. So welcome to the webinar, Dr. Wong.
Thank you, Anses. Can you hear me well? Can you hear me well?
Yes, sir.
Yeah.
You may go ahead.
Thank you. Thank you, Mike, for that presentation. I enjoyed reading your slides last night, and I learned quite a few things also from your presentation this morning. And I've been asked to react to two presenters. So I actually divided my reaction into two. So I'll give an introduction for the first presenter and some comments on her presentation. and then also a reaction to the second presenter later on, and then conclude for both presentations. So this is the session on transparent governance and accountability. And the organizers say that this is about evidence-based decision-making during the pandemic. So I want to talk about how researchers and policymakers interact with each other. And many times, oftentimes, it's like two cultures, or two countries or communities talking to each other. They have different ways of doing things and different priorities. For example, for researchers, the way they think about policy and research is that this is a sequential process, and it should be a rational process. For policymakers, on the other hand, this is an indirect process, and it's not necessarily logical. So problems are not always recognized. There's a long interval between research and impact, and the relationships between research and policy is often a black box. Researchers, on one hand, think that research contributes to valid knowledge, but for policymakers, research is only one input to decision making, and sometimes if their experience clash with the findings of the research, they're skeptical about the findings. Researchers are accountable to peers and funders, but policymakers are accountable to politicians and the public. They also have different priorities. For researchers, the priorities is to expand their opportunities and influence, while for policymakers, it's to maintain a system of good governance and satisfy politicians. For researchers, their value is independence of thought and action, while policymakers are oriented to provide high quality advice to politicians attuned to particular contexts and specific decisions. So this is the framework I'll use to comment on the two presentations. So first, for the Parañaque study, I'll comment first on methods. The reason I really like this presentation is very upfront. They were it was very transparent on the limitations of the study. That these are findings that are limited to people with internet, are Facebook users and have phones. So it's a very select group. And it may be, although the findings may be applicable to people in this with these characteristics, they may not apply to other users. The method that they use is that they got people to volunteer using the ad, and then they sampled from it. But this is very different from sampling from, for example, a list of households. If the people who volunteered are very different from your target population, even random sampling doesn't address the issues of bias. As Meg has shown that their sample is very similar to the Metro Manila population in terms of sex and family size. There are differences. So, compared to the Metro Manila or Philippine population, this sample is older, has higher income level, and is better educated. So it's really not representative. But it's important to point this out to policymakers, so that they can also temper the policies or the decisions that they need to make. So this is a good practice for researchers to do. What I would recommend for this study, and maybe also for the study that you're going to do for the DOH, try to also outline what steps that you took to address the non-representativeness of the sample. No studies, even if there are limitations, so it's completely wasted. There are always lessons to learn from each study. So if you can reassure the policymaker how it can be applicable to their target population, they can also adapt the findings of the study. Some other things that you can do are also address head-on the issue of biases. So because of your sampling method, what are the possible biases? What are the magnitudes? Even if you can just estimate it on a qualitative basis, and what are their directions? So because of your resulting sample and how it differs from your target population, are your results biased away from the null or towards the null? Are they more similar or less similar? And then given this knowledge, policymakers can adjust your recommendations before they make their decisions and their policies. I think that's so. You have the statement that the practice of non-pharmaceutical interventions may be behavioral rather than structural. But I think we should also consider that some of these may be structural. For example, how can people physically distance at home when sometimes a lot of them live in one home or one room houses? With regards to face masks, I don't know how the questions were asked, but we have to differentiate between not knowing face masks are necessary from not accepting that the sacrifices of having to wear face masks outweigh the risk of getting an infection, and also differentiating that from the cost of face masks. They may understand its usefulness, accept that they want to make the sacrifice to help other people, but they may not be able to afford it. Although face masks are inexpensive, it quickly adds up if you have to change every day. And also recommend taking a social determinants of health approach to this. So just providing a communication campaign may be insufficient. That assumes that the reason people don't practice is because there's a knowledge deficit. But from many other examples in public health, cigarette smoking, alcohol abuse, seatbelts, helmets, we know that even if you provide people with information, they may not necessarily change their behavior because of structural causes. So what this pandemic has shown us that there are many unaddressed issues in housing, food security, jobs, and health. And since we now have the attention of policymakers, it's also a good opportunity to try to push this forward in the agenda. I think that's my last slide. Yes, I reserve this for the next presentation. Thank you.
Thank you so much, Dr. Wong. So now we will open the floor for Q&A from the collated questions raised by our online participants in the chat box. So Megan, for the first question, we combined similar questions. So these the questions came from Mr. Leonido Olobia and Ms. Kathleen Lentija, Licensing Officer 3 from the Department of Health. So their question is mainly on the translation of your recommendations or the findings from your study to local policies or local ordinances. So their question is how were your recommendations, the findings from your study, were able to influence the policies that came out or that were developed by the local government of Parañaque, or their strategies in ensuring that this will increase the health literacy of their constituents in Parañaque?
Yeah, thank you. It's a great question, and honestly, for us, it's if people aren't using this study, then for us, we haven't done our job well. So I'm so glad that they asked. So yeah, the results were used by the city in a few different ways. And I'll specifically speak to the health team because that's what I've learned the most about. And what we heard from Dr. Olga and her team was that they actually conducted a series of Zoom meetings to share our results and recommendations with homeowners associations. They came up with various IEC materials advisories, ordinances, and even executive orders to strengthen awareness specifically around hygienic practices that could take place beyond just staying at home, and also to promote knowledge around difficulty breathing as a key symptom that people should be aware of. And so they also incorporated that into the education for their health workers, that their health workers were focusing on those particular messages as they spoke to members of the general public. Honestly, I don't have up-to-date information on whether or not this translated into changes on cash transfers at all. So I wish that I could speak to that, but I can't. But we are really hoping to learn more about that in the next few weeks as well. Yeah.
Thank you for that. So
can I speak to one of the questions that was also raised in the reaction? Would that be okay?
Okay, go ahead.
So I really, really appreciated the point around steps being taken to address non-representativeness. And one of the ways that we're thinking about this is actually thinking about it kind of on the opposite side, which is we know that the population that we targeted here is not representative necessarily of the broader population of the various geographic areas that we're targeting. So instead of saying, okay, what are all the different ways that we could try to make this a more representative sample, we're trying to take conclusions from what we learned from those particular groups and see how could we reach those that population. So, for example, we feel really confident using this method for the DOH study because the result is going to be communications campaigns that will in large part be pushed out online and through TV ads. And so we're like, okay, if people are already online to respond to our survey, then we would expect these are the same people who would be online and potentially be seeing ads and campaigns. And while we don't know for sure that the people who are watching TV are the same ones that are on Facebook, we would expect that there's probably greater overlap between them than just a random sample. So it's a really important point. We've thought about it a lot. We would not recommend this method for, trying to target poorest of the poor households or, certain demographic groups. But in the absence of other lists that exist and understanding how important it is to get these messaging campaigns right, we feel like, okay, it could be a fit in this case without another option. Yeah.
Thank you for that. So we have... Okay.
Yeah.
Dr. Wong.
Yeah, thank you, Meg. I think the important point here is who is your target audience? No? Who is your target population? No? So immediately that since you sampled from Facebook, no, and you then roll out the ad in Facebook, so there's a match, no, in terms of research subjects and targets of the communication campaign. But if the goal of your communication campaign is to reach beyond that, no, using this method will miss out on a lot of your target respondents. Thank you.
Absolutely. Yeah, we're very, very aware. If anyone has a comprehensive list of phone numbers of people in the Philippines that they'd like to share with us, we'd love to use that instead. But yeah, we're very aware that there's limitations. And I mean, I think COVID has just made us all have to get really creative about how we can, reach our target populations or approximate them in the absence of other methods. Yeah, but thank you so much for raising it. It's a really important point.
Yeah. Often the people who need to hear the messages are those who don't have internet, who don't have Facebook, and who don't have phones.
Yeah, it's really true. I think we are very, very curious to see who else is doing great work in this area and finding ways to reach those populations at this time. For us, the limitations, we haven't figured that out yet. But if others have examples of great ways to reach those, especially marginalized or, offline populations, we'd be really, really excited to learn more.
Yes, that's a great insight on equity in research methods. So we have to ensure that the people that also needs to be reached or covered will be addressed by innovative sampling methodology. Thank you for that. So the next question from Mr. Leonardo Alcantara Jr. is the gap between high awareness on prevention measures and low behavior related to the type and source of information and communication medium being used.
I'm sorry, I'm trying to follow that. Can you say that one more time?
Okay, again. So is again, yeah, sorry. So is the gap between high awareness on prevention measures and low behavior is it related to the type and source of information and communication medium being used? Was that covered in your KAP study?
Interesting. Yeah, no, that wasn't directly covered. I mean, to be honest, we didn't ask a ton of questions about behavior on certain prevention measures. We asked people like if they were going out. I don't even think we asked them if they washed their hands, because basically what we know is that people, all of us, really are not great at accurately reporting, what specific measures we've taken, whether it's did you wash your hands properly, or did you sanitize your hands, or how long did you keep your mask on? So we didn't spend a lot of time asking those questions because we know that they're kind of like notoriously hard to get accurate answers in surveys like this. Yeah, there's always gaps. We did a study on hand washing in schools in several cases over the last few years around the Philippines, and often found, I mean, this is with children, but if you ask them, did you wash your hands? They'll tell you yes, like 90% of the time. But when you sit in the back of the classroom and watch as they leave the toilet, do they wash their hands? At best, you're seeing, 20%, and most of the time you're seeing closer to 5%. So we are very aware of the limitations of these types of self-reported surveys to getting at those behavior change, those captures of behavior. And so that's why we were asking more about knowledge, again, limitations of the method, but just wanting to get the most out of this survey that we could without trying to make bolder claims than would be appropriate in this case.
Thank you for that. So we have one last question, unless there are last minute additions. So the question is again related to LGU. So there's a really strong framing on the role of LGUs in the COVID-19 response or in policy development for their constituents. So how do we maximize the role of local government units or prepare them further in generating the necessary evidence, not only for policy development at the local level, but to also contribute their best practices at the national level?
Yeah, I mean, it's such an important question. I'm glad it was raised. This is a tricky one for me. I live in the Philippines most of the time, but as a foreigner, I think there's real limits to exactly how much I can comment on LGUs. So I do just want to be cognizant of that. I think what we've seen from our experience working with Parañaque and a few different projects now is that there's so much great work going on there, and that there really is an opportunity to essentially run studies like this in some of the cities that we know are doing a great job with their city health departments, and use those as case studies, like exactly in a forum like this. And, here what we found is, even in a city health department that's quite well run and extremely well respected. And, I know that Dr. Olga is called in all the time to speak on her experiences because of her leadership and her exemplary work, that even there, they're struggling so much in COVID. And so my hope is that other cities can learn from, the struggles that Parañaque had, and then, potentially how they've responded over the last few months. But I think, I would be really, really interested to hear from others too. What are the great case studies of LGUs that are doing a good job running, rapid studies, but then also sharing the results that others can learn from them? I think just quickly, what I'll also say is, I think there's often this idea that to run a study, it has to be something massive. It has to be months long, and really speaking to that paradigm between policymakers and researchers that was shared. We don't necessarily always believe that paradigm has to be so split, right? Research can be designed to answer policymakers' questions and to get them answers really quickly so that they don't have to wait months. And so that is a huge part of how we tend to work. Say, what are your questions? How can we get you the best evidence possible in the shortest amount of time around your decision-making priorities? And that's how we designed this study. And, I keep talking about limitations because, with economics and public health training, it's really drilled into us to be very, very cautious about, not over extrapolating from what we learn. But that said, there's still lessons and really important findings that can come out of a rapid study like this that can improve city health policies. And so I think our other recommendation is don't let like the perfect be the enemy of the good. And if you can do a rapid study, be as thoughtful and as rigorous as possible within your constraints, but do it and see what you can learn, and then hopefully share it so that others can learn as well.
Ms. Megan. So I guess that's a wrap for your session. So thank you so much, Ms. Megan Battle and Dr. Wong for joining us and for sharing your expertise with us today.
Yeah, and thank you to Dr. Wong as well. Sorry. Bye.
Okay. So now we move on to the last presentation for this session. So for this study, we will be joined by Dr. Maria Midea M. Cabamalan. Dr. Cabamalan is the previous director of the UP Population Institute and currently a professor in the same institution. She is also a member of the Board of Trustees of the Demographic Research and Development Foundation Incorporated. Dr. Cabamalan published her articles in journals such as the Asian Population Studies, Studies in Family Planning, and Advances in Life Course Research. Dr. Cabamalan will present her study entitled Beyond the Numbers, COVID-19, the Philippine Population and Policy. So good morning and welcome to the webinar, Dr. Cabamalan.
Magandang umaga. Okay.
Go ahead.
Thank you also to Ateneo and the DOH for inviting us at the UP Population Institute and our partner, the Demographic Research and Development Foundation, to share our research in relation to COVID-19. This presentation focuses on how our discipline, demography, can help inform policy with quality data. And I'd like to emphasize that this is not just my study, this is the study of our institute and of the DRDF. So in March 2020, when the community quarantines began, we started to put together research briefs intended to produce evidence that can help shape the response to COVID-19. These briefs combine data from DOH with data from various Philippine surveys. So as mentioned, since March 2020, we published 8 research briefs, initially covering topics on older persons who were deemed most vulnerable in the beginning of the pandemic. We then published one on hand washing, which was at the forefront as one of the important health measures to prevent the spread of COVID-19. We also published in April as our 4th research brief our observations on the data made public by the Department of Health on COVID-19 cases. We followed this up with 2 research briefs on migration in reaction to the Balik Probinsya Bagong Pag-asa program that was thought to help decongest Metro Manila. As we all know, Metro Manila is the COVID-19 hotspot in the country. We also examined the shift in COVID-19 infections from older to younger individuals. Our latest research brief focused on medical frontliners and their demographic profile, and noted that while we have produced many, we seem to still not have enough. As mentioned earlier, we use the DOH COVID-19 tracker, and I have more to say about this later. And we complement this DOH data with data from other sources, like the longitudinal study of aging and health in the Philippines that we at the UPPI and DRDF have collected. The baseline data of which was collected in 2018. The first follow-up is scheduled for the last quarter of this year, but we're still not sure if we can go to field by then. Another source is the longitudinal cohort study of Filipino children, the field work of which was halted in mid-March when the community quarantines began. This is a 15-year study which we are doing with colleagues from the University of San Carlos Office of Population Studies and from Xavier University's Research Institute for Mindanao Culture. We also use data from the PSA, or Philippine Statistics Authority, such as the 2015 Census of Population, 2017 National Demographic and Health Survey, and the 2018 National Migration Survey, which the UPPI implemented. Incidentally, I would like to encourage everyone to participate in the 2020 Census of Population and Housing, which is currently ongoing. So allow me to preface the presentation of this research briefs by showing you this age, sex, population pyramid. What this shows is that the Philippines has a young population. What does this mean? This means that the proportion of younger age population is larger than the older age groups, and this is reflected in the wide base of young individuals compared with the top representing the older population. This is a result of interplay of various demographic processes. The Philippine population is estimated to be at about 109 million mid-year, but with the 2020 census now underway, we will have an update numbers in the next few months. Now, in the early days of the COVID-19 community transmission, infection mostly hit the older persons. Hence, this was the first topic of our research briefs. Data reported in March by the DOH showed that among the COVID-19 positive individuals, a disproportionate large percentage are in the older ages of 50 and over. Furthermore, there is a highly imbalanced sex ratio among COVID-19 positive cases, with a higher proportion of men starting at age group 30 to 34 and persisting to the older age group. COVID-19 data also initially showed that those infected also have other diseases, such as hypertension, heart diseases, diabetes, or respiratory disease. For older adults, these risk factors are highly correlated, as older people are more likely to have one or more of these conditions. As we all know, it was recommended that those with these comorbidities are required to remain at their homes. Of course, there are some exceptions. But using data from the 2018 LSAP, or Longitudinal Study of Aging and Health in the Philippines, we find that more than half of older Filipinos have at least one of the risky comorbidities of COVID-19. More women than men have at least one condition. Those in the youngest age group have the lowest percentage reporting at least one condition. By socioeconomic status, the percentage with at least one disease condition is highest among the upper 20% of the population and lowest among the poorest. Applying these percentages to the estimated number of older Filipinos gives us an idea about the potential magnitude of public health problem if older Filipinos are not protected from the risk of contracting COVID-19. Of the estimated 9.5 million Filipinos aged 60 and over, 5.5 have existing high-risk conditions. The second research brief also focused on older persons and their economic vulnerability. Still using the LSAP data, we showed that 46% of Filipinos are living below poverty line at the time of the survey in 2018. Not surprisingly, 57% of older Filipinos reported they have some or considerable difficulty in meeting household expenses. The older population, by virtue of their age, are expected to have retired from work, or at least those who worked in the formal sector should be receiving a pension after retirement. But pension received by older Filipinos is not enough. While 42% receive a pension, only half of them consider it as their most important source of income, with comparable levels for both men and women. Many older people have fragile and informal sources of economic support. Women, for example, report financial transfers from children as their most important source of economic support. 10% from children abroad, 26% from children within the country. Earnings from work comes second, while pension is the third most important income source. As the country anticipates prolonged impact of COVID-19 pandemic, the conditions of older Filipinos need special consideration, not just due to the health-related risk, but also from the point of view of economic vulnerability. The government should also not forget households with economically disadvantaged older persons when thinking of assistance to families and households. Now, for our third research brief, we focused on a seemingly simple intervention, that is hand washing, and I'm happy to actually hear the previous presentation talk about hand washing as well. Regular hand washing will obviously require access to water and soap. However, based on the 2017 National Demographic Survey, not all households have a place for hand washing, and if they do, not all households have both water and soap in their place for hand washing. Vigorous promotion of proper hand washing practices will not be effective if there's no soap and water in the households. In all, 3 million households, or about 15 million Filipinos, may not be able to comply with the recommended hand washing practices because they do not have a place for hand washing in the dwelling unit, or they lack water and soap. Results from the longitudinal cohort study of Filipino children, which asked 10-year-old children at baseline a few years ago, showed that on average, children wash their hands 3 times a day. 76% said they wash their hands before eating, while 50% after eating. Only 19% of the 10-year-old Filipino children wash their hands after using the toilet, and a third said they wash their hands whenever their hands are dirty. The COVID-19 crisis underscores the need to ensure a steady water supply during this time of crisis, to ensure the availability of soap, including maybe in the market or in the relief packages being distributed to households. Both children and adults alike should also practice proper hygiene. We also prepared 2 research briefs on migration, as mentioned earlier, in reaction to Executive Order number 114, or which that institutionalizes the Balik Probinsya Bagong Pag-asa program as a pillar for balanced regional development. Using the 2018 National Migration Survey, we showed that NCR was the most popular regional destination for first-time migrants, followed by Calabarzon and Central Luzon. Note that majority of internal migrants in the past 5 years are in the prime productive and reproductive ages. More than half are below age 30 years old, and a mere 5% are 50 years old and over. More unemployed have moved within the Philippines in the past 5 years compared to the employed. We recognize the good intention of the Balik Probinsya program, but we also pointed out that it should recognize the economic triggers of population movements. We also pointed out that if migration is to be an adaptive mechanism in response to COVID-19 crisis, any internal migration policy should take into account the characteristics of migrants and their varied motivations for moving. Employment is a top reason for migrating, followed by housing-related reasons. So unless the destination provinces can provide these and their other needs, it may be difficult to draw migrants back to the provinces. As we wrote in our research brief, we need to give return migrants enough reason to stay in the provinces for good. Our medical frontliners are heroes during this pandemic, but we seem to have a shortage amidst a surplus of trained health professionals. Despite the huge number of health professionals that the country produces every year, there is still a shortage of health workforce employed to meet the standard requirement for the country's growing population. A large factor of this is the continuous outmigration of health professionals. Based on the 2015 census, almost a fifth of the total health professionals in the Philippines are working overseas. More skilled and experienced health professionals are likely to have left already for better opportunities in other countries. Through time, this outmigration is motivated by factors such as low pay and lack of opportunities for professional development, coupled with increasing costs of a medical education. It is important to underscore the long-standing issues related to human resources for health, such as low pay, high turnover rate of trained personnel, and outmigration of the country's experienced health professionals. The government's recent move to increase the salary of newly hired nurses is a welcome development to keep them in the service, even as the government has directed the temporary stop for them to leave for overseas employment. But the recent upgrading in the salary scale of government nurses may still not be enough to address this issue. Now is a good time to revisit the salaries and benefits of health personnel to make sure the hazards of their profession are taken care of and their services are well compensated. As the world reels from the effects of this global pandemic that require an even greater number of trained health personnel, the lure of work abroad threatens to further diminish the already inadequate human resource in the country. The government will do well to stem the health worker migration by giving them enough reason to stay and serve their country where they are needed most. It's September now, and we have been in the longest lockdown in the world, more than 5 months and counting. COVID-19 infections has increased to almost 240,000 as of yesterday. That's close to 4,000. In our 7th research brief, we noted that there had been a shift of COVID-19 infections from older to younger individuals. Notice the changing shape of these age-sex pyramids. From March to August, the median age of positive cases declined from 50 to 36 years old. This is the case for both men and women. Moreover, at the start of the community quarantine in mid-March, the age group 25 to 34 accounted for 20% of COVID-19 cases. The share dropped to 13% 2 weeks later, but thereafter had continuously increased and reached 30% in August. Similarly, an increasing pattern is also found in the younger age groups and those 35 to 49 years old, while the share of COVID-19 positive individuals in the older ages of 50 and over had declined. In addition to age structure, it's important to understand how different age groups interact in societies as manifested in living arrangement, age composition of the households, and intergenerational contacts. The spread of COVID-19, for example, in Italy, was attributed to higher intergenerational contacts as younger family members tend to commute from cities to villages to visit their parents and grandparents. Based on the 2015 census of population, the average household size in the Philippines is 4.4. An overwhelming majority of Filipino households have members in the working age, 15 to 59. 65% of members below age 15 years, while almost a quarter have members who are 60 years old and over. Meanwhile, as just shown, a noticeable spike in the number of COVID-19 infections is found in the age group 25 to 34. This is the working age population, and they are likely more mobile compared to the other segments of the population. As the level of community quarantine is lowered and restrictions are eased, the mobility of this working age group has likely increased as well. This should be cause for concern because COVID-19 transmission in younger age groups may go undetected for a longer period because they are also less likely to have coexisting health conditions and may be asymptomatic. Based on COVID-19 data drop of August 29, a third of the asymptomatic cases are found in the age group 25 to 34, and about 1/4 are less than 25 years old. Well, before I end this presentation, I would like to emphasize that in our research briefs, we excluded data from individuals with incomplete information. For example, incomplete information on age or sex and dates of recovery, which I actually didn't show much about that in this presentation. The median age of deaths is an example of why age, sex, and date of reporting are important. As you can see, at the time we published our 7th research brief, there was a 4-year decline in median age of death since the start of the pandemic. That would be 68 in March, and it dropped to 64 by July. But as of August 29, the figures show 65 instead of 68. So this is a relatively more alarming than the updated data, which shows only a 1-year decline. Of course, this is doubly important when the case numbers are few, which makes statistics sensitive to changes. I would also like to point out that when we published our first research brief, which focused on older Filipino population, we used the COVID tracker data of 25 March. In particular, we focus on 2 of the most basic demographic factors, age and sex, and use information on the epidemiologic link to examine risk factors related to COVID-19. We have been preparing an analysis of case fatality ratios, but data we needed for this analysis were dropped from the publicly available data. An identification of possible correlates of deaths and recoveries could also be done if these data were made available consistently. For example, at some time, details on symptoms and dates were removed from the tracker, as well as epidemiologic link and the status of condition. We also wanted to do an analysis of COVID-19 infections among OFWs, but the initial data given in the beginning were eventually not updated, and there's not enough information to proceed with an analysis. By April, the NCOV tracker was replaced by COVID-19 data drop, the file structure of which has gone through many iterations since its launch in April. We do welcome the change, as we need not manually copy the entries anymore, and instead we can just build our database by copying and pasting the data. However, as we have stressed in our 4th research brief, we need reliable data on COVID-19 because apart from the observations I have already mentioned earlier, we noticed in the data drop that some variables are no longer made available, the date format are changing, there were mismatch codes, there were changes in entries in the variables on age, sex, removal type, place of residence, there's change from with information to no information. In general, we found inconsistencies with previously released information. While recognizing the difficulty of collecting and collating data comprehensively, we would like to appeal to DOH to share to the public all available information they have collected on COVID-19 cases and to do so on a timely manner. As with all data, we practice caution in interpretation. Aside from the underlying undercount as an artifact of testing, factors including clerical error and those described above also affect the data we have for analysis. We would also like to appeal to DOH to continue improving the data you're sharing to the public. The principle of GGO, or garbage in, garbage out, is important to keep in mind. If there are other information you have been collecting collecting, such as maybe family relations among COVID-19 positive individuals, perhaps, it would be best if you can also make them public so we can have a better analysis of the COVID-19 positive individuals. The more detail you provide, the more salient and actionable the data becomes. We also appeal for consistent and timely reporting. Looking ahead, we encourage the investment in a system to monitor diseases and deaths, which will make us ready for the next crisis, which we hope we don't have, and will also serve to complement the vital registration system, considering the low reporting numbers. Through these research briefs, we hope we are able to contribute to the understanding and identifying vulnerable groups in this COVID-19 pandemic. And finally, I'd like to quote from our fourth research brief: as demographers, our analysis are as good as the data we use. And if we would like to continue to inform policy, we should have good quality data. Thank you very much.
Thank you very much, Dr. Kabamalan. So we now open the floor again for our reactor. So we welcome back Dr. John Wong. So welcome back, Dr. Wong. You may proceed.
Thank you. I have to do. Let me just move my slides to the second part. Okay. So the major limitations cited by the author, and thank you for the presentation, is the data quality problems. I myself have had an opportunity to work with this data, and in my months of working with the IATF, I have had to wrangle with this data also on a daily basis. And I've seen how, or I've identified what are some of the causes for this problem with data. So first of all, we live in a devolved health system. DOH may aggregate the data, but they don't produce it. The data generators are at the LGU level, and because of the local government code, there's very little that the DOH can do in terms of mandating them to report the data. To the credit of DOH, they've always accepted responsibility for the quality of the data without pointing fingers, but at the same time working with the LGUs to improve on the quality of the data. Second, I think it's very important to realize that part of the reason we have such an imperfect health information system is we're in the middle of a pandemic. In the middle of an outbreak, it's really difficult to be collecting data on the fly. Sometimes the data you collect initially may not be what you need later on to make decisions, and you may discover this data needs later on. So that's why data structure can change. And thirdly, although we've experienced a lot of problems since the start, I think the DOH has done its best in building the ship while it's sailing it at the same time. I've seen how its response to data issues identified by researchers have improved, and the speed at which it's responding has increased also. For missing data, they've tried to retrieve the data from the LGU level, and if that falls short, they try to do data imputation methods. And finally, in the name of transparency, they've always come up with technical notes, identifying the technical issues and how they try to solve it. This provides valuable information to researchers on how they can tailor their analysis also. I also have some questions to the researcher. So we see a shift in the age over time. Could this be a factor of sample size? In March, the number of confirmed cases was 50, in August is in the hundreds of thousands. No? So could it be that, and we see that as the months wore on, the age-sex pyramid actually began to look more like the base pyramid, no? The national pyramid for age and gender, age and sex. No? The second cause of this is, could it be that this is also a factor of increased testing? Initially, there were very few tests, so only hospitalized patients were tested, and most of them were the elderly. You know? So as testing moved out to being able to test patients on an ambulatory basis, no? We see younger people, no, being tested and being confirmed. No? Other questions I had for the researchers are, given the large amount of missing data, what can still be inferred, no, from the data, no, or from the results, no? And what are your recommended policy implications, no, with regards to the age-sex structure, no, of COVID-19 infections? Let me just conclude, no, and this is a conclusion for both presentations and also for the theme of governance and transparency, no, as a whole. So earlier I've given recommendations for the researchers. I also have some recommendations for policymakers. No? The media briefings that DOH has been conducting has been really good, no, for educating the public about the science of COVID, but also about how the scientific process is done. No? There's a lot of uncertainty that comes with the certainty. No? DOH also needs to step up on its research governance, no, for the COVID-19 pandemic. No? So we need to come up with a research agenda soon. No? It's been good. One of the good things I've realized about this pandemic is that we do actually have a lot of researchers, no? And a lot of them are willing to step up, no, to the plate, no, and help government. No? But all these efforts, no, needs to be guided. No? Policymakers have to tell researchers what are the decisions that they need to make. No? What is the data that they need. No? And then this agenda has to be backed up by funding. And finally, we also need to make sure that research that's published, no, although the pandemic has been moving very quickly, and researchers have come up with policy briefs, no, very rapidly, no, before they're published, before they're peer-reviewed, no, to inform the public and also government. No. It's still important to put a peer review process in place, no, to ensure that research, no, is of good quality. No. Going forward, no, for treatments and vaccines, as we come up to the deadline for the end of or the completion of phase 3 clinical trials for some vaccine makers, no, and also for some local treatments that are being pushed, no, we have to make sure that we let the science lead. No. I understand that there are many other considerations, no, political, no, the urgency, no, that may lead government, no, to make other types of decisions, no, but we have to make sure that we base these decisions on science. No. Government has also tried a lot of interventions, no, since the start of the pandemic, no, a series of quarantines. No. But it's also important to evaluate, no, and publish these evaluations of how each of these interventions have affected the pandemic. No. For example, the series of quarantines may have lowered cases over some period of time, but has it led to excess deaths, no, or has it led to excess morbidity, no, from non-COVID cases? No? And then finally, no, this type of research forum is good, no, for policymakers and researchers to meet. No? But it's also important, no, to to have a seat at the table for the public and for civil society, so that they understand how science is done. And this is a good opportunity, because as we see, in media, the public has been paying attention. So it's a good opportunity to develop science also, in the country. Let me end with this quote. This is from a play, a drama by Henrik Ibsen, Enemy of the People. One of the characters there, Dr. Stockman, is a public health official. He was warning the town about a public bath that they were going to install to generate income. So he discovered that they found viruses and bacteria in the bath, and that it would be unsafe to open the bath. The policymakers, on the other hand, even the public, were saying that they would lose income because of this. It would be expensive to renovate. But Dr. Stockman is sort of a little standoffish also. He said that people who wouldn't listen to him are better off leaving Norway, so that only the good people will remain. So in the end, the town ransacked his house, burned it, tried to evict him, including destroying his best trousers. So he ends the play by saying that you should never ever wear your best trousers when you go out to fight for freedom and truth. And the lesson here is that as researchers, although we know our methods, we know our science, it's important that we also work with policymakers. We have to be ready to dirty our hands, dirty our feet. Go join the decision makers in the trenches to try to solve this problem. Thank you.
Thank you so much, Dr. Wong. So, Dr. Kabamalan, you may now address or react to Dr. Wong's insights or inputs to your presentation. So you may proceed, po.
Okay, salamat po. Thank you for the comments, Dr. Wong. I would just like to comment on a few. With regards to age shifts as a factor of sample size, we're talking about all the COVID-19 positive cases. So that's almost like a census, so there's really no sample size to talk about there. But if you meant maybe there are fewer people from before, there's really that shift from old to young population. Actually, the same trend has been found in other countries as well. With regards to policy implications, the shift from old to young, I think I mentioned a few in the presentation, but I would just like to add, because the younger ones are the ones working, then we should also put in place, workplace protocols with regards to, this, so that infection will be minimized if it's not totally eradicated within the workplace. You mentioned something about devolved health system. We do understand this, and that some of the data really comes from the LGUs. Then maybe it speaks to the need maybe for training at the local levels, so that they are more informed of what to do and how to address issues like this in the future. Thank you. If there are other questions.
Dr. Kabamalan, thank you so much. So we do have another question raised by Ms. Jasmine Antandingan. So from a demographer perspective, what are your insights or recommendations in improving the conditions of all Filipinos across all age groups, like based on what you have inferred, or based on what you have taken away from the data that you have worked on this?
That's kind of a broad question, So I guess it's really, really follow health protocols all the time, wear mask, wear face shields, keep distance, wash hands, really, it's these are the best things we can do in this time of the pandemic.
Then there's another question. I guess this is also general, but I guess from your perspective, how do we support evidence-based policy development in the coming months, or even ensuring that they remain stable or of good quality even after a pandemic scenario, in a post-pandemic scenario?
Actually, we look forward to the end of this pandemic when the data would probably be in better shape, because as mentioned by Dr. Wong earlier, we're this is an ongoing process. So DOH is also improving the data system, which we sincerely appreciate, But by the end of this pandemic, when all the data are in, then maybe there's, one time, a check of the data, and then we can analyze that data once again, and that would be the basis for a more informed policy.
So thank you for that, Dr. Kabamalan. So I guess there are no more questions or none that are being fed to me. So I guess this is a wrap for your session. Thank you so much for joining us. And thank you, Dr. Wong, for joining us once again as the reactor for this third presentation. So now we come to have arrived at the synthesis, or near the tail end of this session. So I'll just deliver my synthesis. So this session highlighted the importance of evidence in decision and policy making. Directives cascaded to the public should not be arbitrary and instead be informed by good quality evidence. Asek Ronquillo mentioned that the health system accrued early wins, specifically in maternal health and early childhood development indicators, which sets the stage for a healthy life course. It is thus important to protect the initial gains of the UHC reform, which will be delivered by an evidence-informed strategy and amping up our sector surge response capacity to ensure stable primary care and responsive and resilient health systems during and even after a public health emergency. Dr. Dance highlighted the comprehensive evidence base utilized to recommend appropriate policy action. Nonetheless, an effective cascading of this policy action will only be effective and achieve its intended reach and impact if we are also cognizant of the way we frame or the messaging or appropriate risk communication. We should steer away from fear-based positioning of messages emanating from different sectors, because this impacts how the public will respond in its uptake of policies we cascade. Ms. Battle reported the trade-off between knowledge gaps and structural gaps in the KAP study of ID Insight that they conducted in Parañaque. This, however, should not be treated as a dichotomy where one is prioritized over the other. Effective response is a shared responsibility between the individual and enabling reforms in structures and systems. Another key insight from her study highlights the role of LGUs in accelerated and effective response. As such, good practices from LGU should be a welcome addition to the evidence base, because they reflect the insights on the lived realities and nuanced contexts of local communities. And finally, Dr. Kabamalan showed us that there are different ways to analyze and interpret data. She showed, from a perspective of a demographer, the different ways of looking at the data provided by the Department of Health, which contributes to providing a more complete picture of the COVID-19 cases. Nonetheless, she highlights the importance of investment in readiness towards more proactive systems that will facilitate the generation of good quality data, because as Dr. Wong mentioned in his reaction, we do have a lot of data analysts and researchers that are willing to step up and to help the government, that they can only do so much based on the data that they can work with. So the efforts need to be guided by good data. And so that closes the session on the first session for this National Health Research Forum for Action. So thank you so much for joining us. And as a few reminders or announcements. If you encountered problems during the webinar, lost connection, or did not finish the webinar, links to the webinar replay will be sent to your registered email address. To receive a certificate of completion for this webinar, please take the quiz and answer the evaluation via the link which will be sent to your registered email address. Participants are only allowed to take the quiz once. You need to score 80% or higher to receive a certificate of completion. Otherwise, you will receive a certificate of attendance. The webinar quiz will only be available for the next 48 hours, so make sure that you take it right away. After the quiz is closed, your certificates will be issued at a later date after the verification of scores. As a final reminder, please double-check your email address during the registration. Incorrect email addresses will not receive related announcements. So as Dr. Uhc Villaverde mentioned, this is just the first of the series of webinars on the National Health Research Forum for Action. So the National Health Research Forum for Action invites you to its next upcoming webinar session. So tomorrow, September 9, 2020, at the same time, we will have our second session with the topic of strengthening the local health system. Next month, on the 6th and 7th of October at 1 p.m. to 4 p.m., we will have our third session, which is entitled Ensuring Continuity of Health Service Delivery Amidst Public Health Emergencies. It is divided into two parts. One will focus on the human resources for health and health facilities, while the second part will be the special population, specifically migrant and overseas Filipinos, elderly population, and children. For November 12, at exactly 9 a.m. to 12 noon, the fourth session is entitled Optimizing Financial Resources for UHC in Times of the Pandemic. And our fifth and last session would be on the 15th of November, 9 a.m. to 12 noon, which is entitled COVID-19 Lessons and Ways Forward. To register, please visit the link that is flashed on your screen. And please be reminded that you need to register to all sessions that you wish to participate individually. So we hope to see you there and you will join us in the upcoming sessions. Next is how to register for the succeeding NHRFA session. So to ensure that you register properly for our webinars, here are our reminders on how to register. After filling the registration, please make sure to register to Webinar Jam to gain access to the webinar link. To do this, click the link provided for each session to register to Webinar Jam. Once in Webinar Jam, please click the register button seen at the bottom right corner of the page, so the one encircled. Fill out the form and click the Register Now button. Please make sure and double check that your email address is correct. Again, you make sure that your email address is correct. Wrong email addresses will not receive the link to the webinar. Fourth, you will be provided a link to the webinar. Please take note of this and you will go to this link on the day of the webinar. After a few minutes, you will receive an email containing the webinar link and registration confirmation. You will also receive a notification via email 24 hours before the webinar and 15 minutes before the webinar live to remind you that we are about to start. So once again, thank you so much for joining us today. So for questions and comments about the webinars or to reach the organizers and the secretariat, you can email us at the email address flash on your screen. And for inquiries about registrations and certificates, you may forward them specifically to the second email flash on the screen. So once again, on behalf of the Department of Health, thank you so much for joining us. And this has been Frances Anagan. Thank you for joining us today. And we hope to see you again in our future activities. Thank you so much.
Nasistress ka na ba? Nagpapanik o natatakot dahil sa COVID-19? Normal lang ang ganitong mga reaksyon sa ngayon. Pero may magagawa ka para mapagtagumpayan ang sitwasyon na ito. Ituloy lang ang pangangamusta sa mga kamag-anak at kaibigan gamit ang text, tawag o video. Tiyakin na ang mga bata ay ligtas at nasa maayos na kalagayan. Kung ikaw ay nasa-stress na, huwag itong ibaling sa kanila. Tandaan, anuman ang iyong reaksyon ay maaaring makaapekto sa kanilang emosyon. Gawin sa bahay ang mga nakasanayan upang hindi mabagot o mabalisa sa panahong ito. Basta siguruhing protektado ka laban sa COVID-19. Magdala ng good vibes sa bahay. Sa wastong pag-iingat, ang virus hindi kakalat. COVID-19, kayang-kaya nating tapusin.